Hi, everyone. Welcome back to another journal club hosted by the Chest Journal. My name is Dr. Aravind Menon. I am an intensivist and pulmonologist at the Medical University of South Carolina in Charleston. Today, we have a very exciting paper here. It's on the MUC5B promoter polymorphism and survival in Indian patients with idiopathic pulmonary fibrosis. And we are very excited to have Dr. Dhooria, one of the authors, join us for this journal club. I'd like to introduce my co-moderator as well as the primary author. Dr. Gallo, do you want to introduce yourself?
I would love to. Hi, everybody. I am Alice Gallo. I am a pulmonary critical care physician at Mayo Clinic in Rochester, Minnesota. Excited to talk to you today about Dr. Dhooria's research.
Thank you, Alice, for joining us. Dr. Dhooria, would you be able to introduce yourself?
Yeah, sure. I am Dr. Sahajal Dhooria. I am Associate Professor at the Department of Pulmonary Medicine at PGI, Chandigarh, India. My areas of interest and research are interstitial lung disease, sarcoidosis, and interventional pulmonology.
Thank you, Dr. Dhooria, for joining us all the way from India. So I think we have a lot of time, and I want to jump right into this paper. Let's advancing my slide. Whoops, too many. So this is the exciting paper that we'll be seeing in our journal next month. And so starting out, just wanted to ask you, Dr. Dhooria, what was the rationale for you to undertake this study, and what were you hoping to look at?
So in fact, we started this study looking to answer three important questions. First of all, there has been a lot of data coming in the past decade on this polymorphism, the single nucleotide polymorphism in the MUC5B gene. It's called RS35705950. There was no data on the genetics of ILD from India. So first of all, we wanted to look at what is the frequency of this particular polymorphism in Indian subjects, both the control subjects, the healthy population, as well as patients with IPF. The second question was whether the mutation is associated with IPF or not in Indian subjects. And the third question, where worldwide there the data are few, there are only 4 or 5 studies on the association of this SNP with survival in IPF. So these were the three questions which we wanted to answer with this study.
Wonderful. Thank you. So how did you set up the study design, especially looking at the normal population versus the ILD population, and compare the differences to what is available from the Asian and Western populations?
So when we looked at the literature, we found that amongst Caucasians, a lot of studies from the Caucasian population. So there is a significant presence of this single nucleotide polymorphism in the healthy population itself. So a meta-analysis shows that it is about 11% in the control population. And amongst IPF patients, it is about 35%. So that is the data in Caucasians. Amongst Asians, there have been studies in the Chinese, the Japanese, and the Koreans. There, the frequency is much lower. So amongst the healthy population, it comes out to be a rare allele because the frequency is less than 1%. It's about 0.75% amongst Asians, amongst the normal population. Amongst IPF subjects, it's about 2.1%. But in both Caucasians and Asians, the SNP seems to be associated with IPF. As there were no data from India, so we just wanted to see what is the actual frequency in our population, whether it is closer to that seen in Caucasians or whether it is closer to the other Eastern Asian populations, South and Southeast Asian populations. So that's why we planned the study as a prospective observational study. So we have an ILD clinic going on where we see a variety of ILDs. IPF is one of the common ILDs that we encounter. So we were gathering clinical data of all these subjects, and then prospectively we started the study and we started collecting their blood samples after due consenting procedure, after ethics committee approval. And then we performed a Sanger sequencing after extracting the genomic DNA from peripheral blood cells. And then as we were gathering data on the follow-up of these patients over a longer term, so we got the kind of survival, we could perform this kind of a survival analysis because we had data on the vital status of the subjects. So it was a prospective study, and we have follow-up data. If you take it from the symptom onset of about 4.5 years, a mean of 4.5 years, so that we could have this kind of an analysis.
Dr. Dhooria, I have a question for you. Because I'm fascinated. So everyone who gets to your interstitial lung disease clinic is asked to consent for blood draws, and you have a repository of all of their blood samples?
No, previously we did not have that, and we took consent particularly for this study, and we also got the consent of our subjects for use in other genetic studies also, a general consent, apart from this particular consent for the MUC5B study. And later now we have started another kind of study as part of a network wherein we are gathering this blood samples for biobanking, but not at the time that we initiated the study. At that time, it was limited to IPF as part of the study, but also a general consent for further use for research purposes only.
That's amazing.
Yeah. That's great. I think, having a good cohort lends itself to a lot of things that we can use in the future. And having having worked with cohorts, like having that data where you can go, especially if you have that, the genomic data extracted and uploaded into a repository, you can always check for associations. And, the times that we have worked with it, and we have examples of this from various cohorts, like, for example, the Framingham cohort, right? The Framingham cohort started in 1950s to look at cardiovascular risk. Now, it has been through multiple generations, and we have CTs from it. We were able to identify ILA in that, and then try to look at what are the associations and even heritability of that as well. So there is a lot of work that can come out of this, once it's set up. So kudos and congratulations, Dr.
I would like to add here that it is great to have biobanks all over the world. In fact, different academic centers can really build up their own, and then finally those data can be combined. The most important aspect of these biobanks is to have a very good clinical phenotyping of the patients, as good as possible, because otherwise they will not help to that extent. Okay, if you have CT scans, for example, in Framingham, obviously you had CT scans, and so a lot of the thing about ILA started from there, because they had huge amounts of radiologic data. But if you want to really study the clinical outcomes, the clinical phenotyping has to be really good along with radiology. Yeah, no, a lot of the times, we have had a lot of CT scans, and there is, we do subtyping as well. And there is trying to identify, we try to phenotype as best as we can so that we can separate the noise from the signal. You're absolutely right. So, once you have the right phenotype, then we can be more sure about whether what we are seeing is a signal versus it's just a background noise that's because of random, variants of unknown significance versus random mutations that may be somatic, not germline, all that. So wonderful point, Dr. Dhooria. All right. So you mentioned to us how you recruited your cases. Would you be able to tell how you had a control population that you're able to kind of check for what was the difference in allele frequency in the cases versus not cases and controls, but the individuals who are identified in a prospective cohort and enrolled versus the control population within the prospective cohort? So the control population came from some of the staff of our hospital and some of the patient accompaniments who would agree to contribute to the study. And these were unrelated individuals to the IPF patients. And so we have been in the process of building up that control cohort also over time. So that initially we planned the study, then we thought that we might be able to, in the time frame that we planned, we might be able to get about 150 or so controls. So we planned a sample of about controls being 1.5 times the number of cases. And so that's it. And the frequency that you asked me, so the results of the study. So the frequency of this SNP amongst the control population, which was essentially people not having IPF, was about 11.8%, which is close to the figure reported in Caucasian population. So in Caucasians, you have about 11 or 11.2%. So it was almost the same. And even amongst IPF patients, the figures were very close to Caucasians. So we got it in 32.1% of our IPF patients, so almost 3 times that of the control population. And that was also close to the frequency reported in a meta-analysis amongst Caucasians, which is about 35%. So our results, like our genetics in terms of the MUC5B SNP was closer to Caucasians than to other Asians. And the association was indeed found in our study, so we found an odds ratio of 3.5 for the presence of the minor allele and its association with IPF. Amongst heterozygotes who had a GT genotype, there the odds ratio were 4.7, again close to reported in the meta-analysis. And amongst the homozygotes, we got a very few homozygotes because the sample was not a very large sample. It was just 106 patients, although it had the power to report on this kind of an association, but still it was a small sample. So we just got 6 homozygotes overall in the IPF population and 2 homozygotes in the control population. And the odds ratio for homozygotes to have IPF were 8.5. So those were the frequencies, very close to the Caucasians.
Yeah, no, that's fascinating to see, such high odds ratios associated. And we've seen that consistently with the MUC5B, even when did a meta-analysis of the GWAS, it was similar numbers from what I recently published a couple of years ago. I just wanted to bring the attention to table 1 there here. And my next question is, you have like a good cohort here. You've been able to tell us, what the differences are as expected, when you were looking at cases of IPF versus controls. We know that it's a disease of older individuals, more likely in men who associated with smoking. And we are seeing all that same risk factors represented in the population that you have studied here. One of the things that, it was a little different from what I was used to seeing is the higher incidence of pirfenidone. And usually because here, the first drug to be approved was nintedanib, and it's still the only drug that is approved for progressive fibrotic phenotype by the FDA. We usually see nintedanib as the go-to. Is there any reason why you had like a significantly higher number of patients on pirfenidone than nintedanib in your population?
Pirfenidone became available in India as a generic formulation more than a decade back. So I think it was in 2010 that it became available. Generics here are cheaper, much cheaper than the innovator molecules launched by the parent company. And nintedanib became available much later, and it was only the innovator molecule available. The generics were not available. Generics became available only a couple of years back. So our choice was nearly always pirfenidone, because all of our patients, or maybe nearly all of our patients, pay for their medical expenses out of pocket. So we do not have that much insurance coverage. Also, we are a government hospital or a public sector hospital, and we see patients from relatively a lower socioeconomic status. Mm-hmm. So they could not really afford nintedanib at the time we conducted the study. And when nintedanib became available as a generic formulation, really we have started using almost to a similar frequency as pirfenidone. But because my experience with pirfenidone is much greater than nintedanib, so it still remains one of my first go-to options, and I'm happy with the kind of results that I come across with pirfenidone. But yeah, that is the particular reason that in this study we have almost 85% of our patients receiving pirfenidone rather than nintedanib.
That's wonderful.
And just for the curiosity of our listeners, how much do you know average how much your patients will pay for pirfenidone?
It would be about 5,000 to 6,000 rupees. And it is now almost equal to what they pay for nintedanib. Okay. With the generic formulations becoming available.
That's amazing. Here's about $15,000 to $20,000.
Yeah. So yeah, and sometimes depending on the copay situation, they might end up paying copay of. I have patients who pay around $125 out of pocket after if they haven't met the deductible. So
even nintedanib, the innovative molecule of nintedanib was about $1,000 per month therapy, which our patients could not really afford.
Yeah, that's wonderful to hear that you were an early adopter of the molecule after it came out in 2009. I think FDA was still looking at a mortality endpoint, and it was only in 2014 that they were willing to accept a secondary endpoint of FVC for approving nintedanib and pirfenidone. But the earlier trials, as you mentioned, were positive for FVC, halting FVC decline in 2009. That also means you probably have a lot more data to look at. So we are excited to see what you're working on in the future too, to see if you can get a long-term dose effect versus survival effect associated with pirfenidone in your population.
We were finding in India was that a lot of physicians in practice were not prescribing the full doses. But when we started looking at ILDs, especially as a special area of interest, we started using the full dose of pirfenidone, which is 2,400 milligrams. So almost about more than 40% of our patients could tolerate the full dose, and about 25% of them could tolerate 1,800 milligrams per day. So we just were curious whether there is any difference in survival with a full dose or a reduced dose. So or the patients who did not receive any antifibrotics due to any reason. So it could be financial constraints. It could be they could not tolerate the drug. That was the only drug available, only drug affordable at least. So we made three groups: one that received the full dose of pirfenidone, 2,400 milligram; the other who were receiving less than the full dose, which could be anywhere from 600 milligram to 2,200 milligrams; and the third was no antifibrotics. So because we had a good cohort which we were following up longitudinally, we had the data on the vital status of the patients. So we could really plot the survival with the different doses, and we really found that with the 2,400 milligram dose, there was a statistically significant difference between the no antifibrotic group and the pirfenidone 2,400 milligram group, and the reduced dose came in between. So if you see the survival curve, the three curves, so the reduced dose fell in between the full dose and the no antifibrotic group. And it didn't really achieve statistical significance with the kind of sample size and the duration of follow-up we had. So it created some difference in survival, which did not meet the statistical significance for the reduced dose. But with the full dose, we found a statistically significant difference in the survival. Yeah.
Oh, that's great. I got to read.
I hope I'm clear.
No, that makes sense, because that's a clinical problem a lot of us face. Is a lot of our patients may not tolerate. I have patients who come in and say that they're not able to take 9 pills a day. That there's a pill burden, and also the side effect profile of nausea that's sometimes more common with pirfenidone than the diarrhea that's associated with nintedanib. But that's very interesting. And so now, I got to look at that article that you published in 2020, because it's very relevant to my practice. Moving on, you did mention one of your major results with regards to the allele frequency. Dr. Dhooria, would you be able to expand on the other two outcomes that you studied?
So the first outcome was the allele frequency as such, which I said was 32% in IPF and about 12% in control. The second question that I initially referred to was the association. So as I told, the association was there with IPF. For this, we also tested for the Hardy-Weinberg equilibrium. With the controls, it conformed to the equilibrium, but with the cases, it did not. So that reflects that there was so Hardy-Weinberg equilibrium conformity may not be there due to certain reasons. For example, it might be a non-random mating, it might be genotyping errors, or it might be selection bias. So those are the three important reasons why there might not be conformity for a particular mutation or SNP in a population. So in the controls, there was conformity to the equilibrium. That just reflected that there might not be any selection bias, non-random mating, or genotyping errors. But the IPF population was obviously selected, because out of the normal general population, we selected IPF individuals. So that was a selected population. So that reflected a selection bias. that's why in our cases, the frequencies, the genotype frequencies did not conform to the Hardy-Weinberg equilibrium. So that's how we tested for the association, and the odds ratio I've already elaborated. We got an odds ratio of 3.5, which for the minor allele, the T allele of the SNP, which reflects the association with IPF. And it was close to that reported in a recent meta-analysis of about 24 studies. And it was, I think, about 4.1 or 4.2 for this minor allele.
Yeah, no, that was the Dr. Allen's paper, I think, out of the
Yes.
multiple.
Moving on to the third question. So the third question we wanted to answer was whether it was related to survival. So previously we have data from two studies. One was by Dr. Schwartz group, Dr. David Schwartz in America, and that was published in the Journal of American Medical Association in 2013, where they found an association with survival. So the variant allele, it predisposes to IPF, but contrarily, it leads to a better survival among IPF patients. So that was the finding initially reported by Dr. Schwartz group. Then we have had a recent paper from Dr. Paolo Spagnolo's group from Italy, published in 2021, who also confirmed this finding that this SNP might be associated with a better survival amongst patients with IPF. But then we had the contrary data from two other studies. One was by Jiang et al., data coming from China, published in 2015, where they have reported a reduced survival with this variant. Another paper in 2016 in respirology by Van der Wies et al., where there was no difference for survival amongst IPF patients with or without the variant allele. So there is some conflicting data from different studies, but the larger studies have shown that it is associated with a better survival. So we sought to answer this question also. And so we recorded the vital status of the patients, and we had a mean follow-up of about 4.5 years from the date of symptom onset. So we took symptom onset as the point where we start recording the duration, because patients with IPF might remain undiagnosed or misdiagnosed for a long time. And if you take the date of diagnosis or the date when they present to your center, it might not be the right time point to start looking at the duration of survival. So we took the duration of survival from the point of onset of symptoms as reported by the patients, which might have some biases. Obviously, there might be some recall bias in there, but we tried to do our best recording that data. And so we had this mean duration of 4.5 years as the thing, and we had about almost half of our patients died during the follow-up. And then we plotted survival with the variant allele against the wild type allele. And we found that there is a survival benefit with the presence of the variant. So hazard ratio was 0.44 after correcting for gender, person predicted FVC, and the smoking status. So we got a hazard ratio of 0.44, which was statistically significant, just telling us that there might be a prolonged survival with the presence of this variant allele amongst patients with IPF.
I just want to bring up
Yes, we can go to the figure.
You could look at it. Sorry, I think the screen went off for a second. But yes.
So as you can see, there are two curves in this graph. One is red, the other one is blue. So the red one depicts the wild type, and the blue one depicts the variant genotype, which is GT or TT. So the presence of this minor allele is there, the T allele. So if you look at the survival, the y-axis shows the survival probability, which falls more sharply in the wild type group, while the survival looks better in the variant cohort. That is those who have the minor variant allele, the blue graph. So the blue graph has a better survival probability as the time goes on. And if you look at the table, accompanying table, you can see the hazard ratio. And these hazards ratio, when we did the univariate analysis, the female gender and the variant genotype showed a better survival, while smoking was associated with a poorer survival. And when we did a multivariate, we found that the variant genotype was still associated with survival after adjusting for female gender, smoking, and percent predicted FVC, that is the lung function at the baseline. So that actually confirms the findings of the first two papers that I mentioned by Dr. Schwartz and Dr. Paulos Magnolo's papers on studying this mutation and its association with survival in IPF patients.
Yeah. Now, this is very interesting because, there is a lot of interest in why there are some of these changes that we are seeing. Like, as in, why is it that, in some studies you have, women who survive longer with this condition, and there are conflicting studies that say, women who develop IPF actually do poorer. And so it's an interesting area that, there may be epigenetic changes that may play a role. That are sex specific. So it's great that you have this data available as well for us to look at. With regards to your study, you do, one of the things that you mentioned in your paper was, the possibility that these changes could be because of something called index event bias. Would you be able to expand a little bit on that?
Yeah, so index event bias means that if a risk factor is associated with a particular disease, the mere presence of that risk factor might disallow other risk factors to creep in. So it is a little, I'll elaborate on that because sometimes it may be a little difficult concept to grab. So say it is actually best exemplified in the obesity paradox. So patients, like clinicians across the world started realizing, especially intensivists, so Dr. Gallo is an intensivist, and so she would agree that sometimes we find that some of the obese patients who come to intensive care do better than those non-obese individuals. This is also especially true with heart disease. So with heart disease, obese individuals might have a better outcome if they develop a decompensated heart failure or maybe an acute coronary syndrome. They do a little better than non-obese individuals. So people were intrigued why this is happening. Obesity is a risk factor for heart disease and even respiratory failure if you have a particular illness. Like we saw even in COVID, that a lot of obesity was a risk factor for severe disease. So why these people were doing better than others? So that was called the obesity paradox. So what obesity does is it predisposes to a disease, say heart disease. But then many of these individuals develop the heart disease at an earlier age. Right. I'll keep it simple. Let's just think that there are only two risk factors for heart disease: age and obesity. Just imagine that. So if there are two risk factors and obesity leads to heart disease, it causes the heart disease at an earlier age. So an obese individual who gets admitted to a hospital with heart failure, say at 50 years of age, and another individual who is non-obese who developed heart failure at an advanced age, say at 75 years of age. And you saw that the obese individual recovered and went home and the non-obese individual could not make it. But it might have been due to the age as a risk factor, which might act as a bigger prognostic factor than obesity. So both are risk factors for heart failure, but age becomes a greater factor affecting the prognosis and the outcomes. So similarly, what it has been proposed in a lot of genetic studies, and this particular case also, where there are contradictory findings. So you have IPF, so you have this SNP, the MUC5B polymorphism, which predisposes to IPF, but somehow contradictorily, it gets associated with a better outcome amongst IPF patients. So what has been proposed is that, again, we'll take an example. We'll just imagine that there are, say, only two risk factors for IPF: smoking and the MUC5B. There are definitely other risk factors, but for the purpose of understanding this concept, let's imagine there are only two risk factors. Then if somebody has a MUC5B mutation, that person is predisposed to developing IPF. So even in the absence of smoking or with maybe a less pack year of smoking, he or she might develop IPF, while another individual who does not have this polymorphism might require a greater number of pack years, say 40 or 50 pack years of smoking to really develop this disease. in that case, the light smoker or the non-smoker who develops the disease might have a better prognosis because he was not smoking at all. And the smoker who developed the disease might have, say, emphysema, coexistent emphysema, or other risk factors like cardiac risk factors due to the smoking, which makes the prognosis worse, right? That is a simple way to understand that the one risk factor just tends to preclude other risk factors, which may be having a greater prognostic value.
Yep.
So the association of MUC5B with better survival might be a true association, or it might be just an index event bias. It just precludes other risk factors, and thus the risk factors which might have a greater bearing on prognosis than MUC5B itself.
Yeah.
So I hope I was clear, and I'm clear to the audience also.
Yeah, no, that makes a lot of sense. Thank you for explaining that beautifully.
And they must not. It was just oversimplification for the purpose of understanding. They must not go with the idea that there are only two risk factors for obesity or two risk factors for IPF.
Of course.
But if you and these things might be very subtle. So if you look at our paper, and if you look at the patients who had a variant genotype and the wild type. So we took the example of smoking. Smokers are not very different in our data. Smokers, about 50% smokers in the wild type and about 45% smokers in the variant genotype, and they were not statistically significant. So it doesn't come out clearly as a risk factor which is different in the two populations. But there may be subtle things. There may be multiple risk factors which may have a subtle difference in the two populations, which may not get caught in the statistical analysis that we perform.
Yeah, I think that's a great point. And, I think we all agree that there are a lot of unknown confounders, especially when there is, it's not a single gene that is leading to this particular disease. There are multiple, risk factors, multiple genetic associations. There are, and we still don't know the mechanism in which how MUC5B could be leading to more fibrosis. And so it's a great point. That you have raised it, and I think it's a valid issue to consider when we look at similar studies and survival.
Yeah, and the conflicting data on survival that we see from different groups, especially the Chinese data, showed that the survival was actually poorer amongst those who had this variant genotype. So there, the reasons might be either methodological, the way the study data were collected. It could have something to do with the sample size, so different sample size in the different studies. Third, it could really be epigenetic differences or other differences in various ethnic populations. So that Chinese MUC5B SNP might be behaving differently from the Indian one and differently from those in Caucasians. So they may be different. I think we'll need a lot of more studies coming from different populations to really solve this this particular problem, whether the prognosis is really related to the SNP. Yeah.
I agree. And I think the NIH also recognizes that, and there is a more of a push to include more diverse populations into even the registries and the databases that we have, so that we are not enriching for a particular population that might have certain phenotype associated with the genotype, but they might be behaving very differently from other populations. So just especially when we go by at the SNPs or single nucleotide polymorphisms, there is a wide array that you could just get lost in. I wanted to just, I'm very excited about your paper, and I wanted to ask, is there anything more that you're planning, on the same line? Are you able to look at the FVC decline? Because that is an endpoint that we usually follow here. FVC decline longitudinally based on the MUC5B. You have mentioned your initial.
Yes. So we tried. We just had a look at our data, and the problem was that sometimes the spirometry does not get performed at very regular intervals in a kind of just an observational study. Patients may present at different time points. So you really need a very good data if you and that has to be, the spirometry has to be performed well and at fixed intervals to have a good data on that. The other thing is that some of the patients with advanced IPF are not able to really perform a good spirometry. So that was the challenge that we faced in some of our ILD studies, and so we could not report on the FVC decline in this particular study. But yes, it is a very good point, and it is very important to study it, because it's not only the survival which we must know, because here also and in other studies, it was the all-cause mortality which was studied. It was not only the respiratory-related mortality. So whether the variant is actually causing, actually affecting the FVC decline, or whether it is relating to survival by affecting other factors, maybe. Yeah. So it will be very important to have large data on the FVC decline and on respiratory-related mortality in these patients.
I agree. That's very important. And, we all know how spirometry is, there is a certain element of variability associated with it. And, sometimes there are good days that the patient does well, and then there are bad days, and, a very rigorous and regimented way in which we check it at regular intervals through proper coaching and trained respiratory therapist is very important. And that's been challenging, but I think there is some data coming out, like even with home spirometry, there is with the newer ones, we'll be able to get reliable and consistent data. So it's something that we look forward to in the field as well. Those are
I hope home spirometry helps. That'll be a very good thing to have. But if you look at a recent study, the pirfenidone study in PF-ILDs, where one of the primary outcomes was home spirometry, it did not really work for the authors, because that the primary outcome did not get finally met, and finally they had to look at the laboratory spirometry, which was more standardized, where they really found a difference with pirfenidone. So home spirometry has a lot of part to cover before it really becomes a standard of care, as well as it might become a standard of clinical care, but for getting it as an important hard outcome in research will be more challenging, because even with lab spirometry, you have so much variability. With home spirometry, that may even be much higher.
Yeah, I agree with you. I think there was some data out of Canada that was saying that it would be a little bit more. They were able to find some consistency there. I forget exactly the paper, but something to look into. But it's like I said, it's a slow work in this field. And we appreciate all your efforts, and we are very excited about your paper. Those are all the questions that I have. Dr. Gallo, any questions that you had or anything else you wanted to discuss?
No, I'm excited to read everything that comes from the Dhooria database. So I'm really excited for all of the things you're going to do in the future. And I just want to thank you so much for being with us today. I was taking notes, like how I learned a lot from everything that you talked to us today. And I'm just very excited. This is good for our IPF patients. This is good for all our ILD patients. So we just want to thank you for being with us today.
Thank you so much, Dr. Gallo and Dr. Menon.
And Dr. Dhooria, I do want to ask you if our listeners want to find you on social media or want to contact you for research opportunities, how should they do that?
So I'm not on Twitter.
All right.
So yes, but my email is available with all my research papers wherever I correspond, so they can always contact me on that. And I'm mostly prompt to answer my email, so that'll be the way.
Wonderful.
That sounds awesome. Thank you so much for being with us.
Thank you, Dr. Dhooria.
Thank you so much. Thank you. Yeah, nice talking, and it was a very good discussion, and I also learned from the discussion. Thank you.
Great. Yeah, that's what we are hoping to achieve. Everybody sharing knowledge, sharing their experience, and if not, making connections. So it was great to meet you. You might get an email from me actually in a bit, just asking about some more questions, and if we can work something out with regards to kind of collaborating on the data, because I also work on the genetics of ILD IPF. So I saw this paper and I was like, this paper is what we want to discuss.
That's good to hear. So we can always find in each other, a good collaborator, and maybe we can meet up somewhere, someday,
Yeah.
conference or somewhere. So
Exactly.
that
Are you coming to Chess this year? No.
no traveling, no international travel this year. The next year I might. Dr. Gallo, what's your like research area in particular in intensive? I think we are off the recording now. Or
We can
are
be-
still
we can be
recording?
I can cut the recording wherever
Yeah.
you want, so please
Whenever
feel
we
free.
want.
Yeah.
What did you want to say, Dr.
No,
Dhooria?
I just wanted to ask, what is the particular area that you have special interest in intensive care?
Me? So I do a lot of liver research. So acute on chronic liver failure, use of TAG, things like that. And I really like the novel cancer therapy complications. So I have some publications in CAR T cells in the ICU, and its complications. And I have a lot of research also on like checkpoint inhibitors and how they can take people to the ICU. And I absolutely love mechanical ventilation. I love it. So we have a lung heart interaction group that we have proof of concept paper that was published last year, that we can titrate PEEP based on cardiac strain, and it's more sensitive. It's more sensitive than some other measurements that we currently use. But yeah, I do a lot of research, but I like clinical research. Yeah.
Wonderful.
Same here. Mostly our research is also it's clinical research, but
Yeah.
I'm just initiating myself into some laboratory work, and there Dr. Menon would agree that it also offers some other kind of intellectual satisfaction. Although the excitement is more with clinics, and maybe intensive care is really very exciting, where you can really change outcomes. But lab has its own satisfaction to offer. That is.
Yeah, don't get me wrong. I'm a clinical researcher too. I
understand. I know, but you also told me that you're.
But, I would not call myself a basic scientist.
Yeah.
You do not.
Just getting a flavor there is good to have in the lab.
See a gel that
lab. Yes. Even for this study and other studies also, I have Dr. Bal. She could not join, but she is a very good collaborator, always supporting me. And she does the lab work with her set of fellows and PhDs and other staff. But I also try to understand the concepts and get the basics right, and all like the concepts which are very specific to lab studies and genetic studies. So I keep on reading and getting it, but the hardcore lab work is mostly done by Dr. Bal. And
so most of my the learning that I've also, it's a constant learning process. Like, you say you get this degree and then you do this, and then you're going to practice, and then you do research every single time, and I'm like, wait, how did they do this analysis? And what am I looking at? So like, especially with like genetic studies, there is so much that, you can do with bioinformatics, and learning to code, learning to use all the tools that are readily available. It's been quite an exciting journey. So yeah, I'm it's exciting to see somebody else also on that path. So that's great. Unfortunately, I do have to run off, so I might have to sign off, guys. It was great meeting you, and thanks again, Dr. Dhooria, for joining us.
It was very nice meeting you, Dr. Dhooria. Great job, Dr. Menon. Welcome.
Thank you.
Bye. Have a good weekend, everybody.
Bye. Pay my regards to Sahil Khanna.
I will. I definitely will. I definitely will.